push off.
I have still a lot of TB to learn, sir.
No, this is not your level.
So
You tell me when to start. Huh?
Yes. Just a moment. We're just ensuring that we are streaming live. So we are live now.
So you went and say that.
And I'll start the recording also. So Siddharth sir, please, you have the honors of introducing Nene sir. He needs no introduction, but please go ahead and then Nene sir, you can start.
I thought you'll introduce.
No, I'll only introduce. Thank you, everyone. Thanks for coming for the show. And I'm very, very honored to be a part of this because teaching has always been one of my weak points and or weaknesses rather. So I'd love to teach all the time, whatever I know. And I've come here at the behest of two of my closest colleagues who I respect greatly, Dr. Siddharth Yadav and Dr. Agnivesh Tikku. And it didn't take too long to say yes. I was waiting for this opportunity actually. So without much ado, I'll share my screen and move on with business because it looks like a long day at work today. Spinal tuberculosis is, indeed the bugbear of Indian orthopedics and Indian spine surgery, if you may. And the reason for that is that India has given the world of orthopedics a lot of tuberculosis. So most of the stuff that is written around the world about tuberculosis comes from our country, which also means that it makes, it makes our country and our examiners, as far as you're concerned, very passionate about TB. And hence, even though you're a pre-graduate, you're expected to know everything about tuberculosis. And there's, the more you know, the better it is for you. Unlike certain other conditions which are not ectopic or which are not endemic to India, there are, about tuberculosis, you got to dive in, and wherever you go, people will ask you about TB. So this is going to be a bit of a long drawn out affair, but I can tell you it's going to be important for you. You don't really have to worry about this, but in our times, people did ask that in which of the Vedas was tuberculosis mentioned. Dr. Asim Parekh had asked us that question. So generally, that's what I'm meaning is that whatever you know, whatever you hear about TB, try and assimilate it because you never know when it's going to be asked. Definitely, they will ask you about the timeline. Who was Robert Koch? What was his contribution to orthopedics? The contribution of Koch to orthopedics. So one of them is, of course, discovery of the tubercle bacillus. And they will ask you when was the BCG vaccine discovered, which was the first of the anti-tuberculous chemotherapy drugs that discovered. So you got to know that. And when was the massive change of tide? That's when Rifampicin came in. That was in between 1950 and 1960 is when the tide changed. The first drug was streptomycin in 1944. Until then, treatment used to be sanatoria. Today, we know how sanatoria used to work. If you guys are, Agnivesh, if you're still there, is it okay to pick on someone and ask questions, or we'll just keep one-way traffic?
So we can ask questions also. It's up to you. Interactive is more better.
So yeah, if someone in the, I just have a few names in front of me, but can someone tell me why sanatoria were indeed useful? How did people get better in sanatoria before AKT or anti-tuberculous drugs were invented or discovered? Can Arun, can Jasim, I can just see a few names, Gayatri, Dr. Vaishnav, Jitin, can someone unmute and say what was the secret behind people getting better with tuberculosis with no medication, just living in Mahabaleshwar in a sanatorium? So maybe you're warming up. I'll give you the answer. It is linked. Yes, go ahead.
So this is Rahul.
Yes, Rahul.
So most of the patients that we have seen have not gone better with at least without medication.
Right. I agree. But in the past, so TB was a big epidemic in the first part of the 1900s, and there was no AKT. So the treatment of TB at that time, including the royal family, was to send them to sanatoria. Sanatoria were large open spaces with a lot of sunlight. That's the clue I want to give you. And they did get better, and TB would go away.
So Rahul, let me prompt you, is it something like more cleaner air, sunshine, sort of oxygen, anything to do with all of this?
So I think a better atmosphere will only help develop better immunity. And basic thing about tuberculosis is that it needs hampered immunity for like 2 or 3 weeks at least to flare up.
Yeah, so you're almost on the ball, Rahul, and I'm glad you're at least taking up the mic and taking the question, because this is what's going to happen in the exam. A difficult question will be posed, and you have to create an answer while thinking on your feet. So you did that right now. So the deal here is that it has been now noted that vitamin D linked C cell immunity and T cell immunity is responsible for getting the body immune against TB. So today, vitamin D deficiency is one of the common causes of reactivation of tuberculosis, and that's been now proven. And hence, when you were in sanatoria and you were exposed to good sunlight, your vitamin D levels would rise, and that would improve the specific immunity against tuberculosis. And that's the reason why people would actually get better. Also, to take from where you started, Rahul, that when I was a student, we had a good number of people who presented with a post-TB deformity, either spine or hip or something, with absolutely no history of tuberculosis or any AKT given. So at least in our time, we've had patients who've completely recovered of TB in our kind of generation without any AKT. So this is not myth. Also, if you go one step further, some of our colleagues from the north, one generation before ours, used to treat TB with milk injections and immune modulation. So once again, that was a part of trying to build up immunity to try and for your own body to actually treat the TB rather than waiting for chemotherapy. So right or wrong, you got to have this in the back of your mind. You have to have the theory behind you. So well done again. And I'll pick on more people as we go. This is something that you will again be asked in, in what are the types of TB organisms. And I remember when I was a postgraduate, I would actually go back to my Anant Narayan, and we would all, read up those organisms, because everyone knows all the basics. So they're going to ask you, what are the types of tubercle bacilli? You got to know MTB, M. bovis, M. avium, M. microti. So you got to know those names. Normally, orthopedic examiners won't go beyond the names, but you got to know the names. If you know the names, it's one up on you. They'll ask you what's the difference between MTB and M. leprae. That's a common question that's asked by examiners. They will also ask you the names of atypical mycobacteria. What are the names of atypical mycobacteria? And once you know the names, beyond that, they will not ask you. One of the catch questions is, what is Jones bacillus? Again, that used to be one of the catch questions. If you're doing well, they ask you that. And again, you just have to get up and name. It's Mycobacterium paratuberculosis, sir. No further discussion, because no one knows more than that typically. But if you know the name, it's good on you. All right. I'm going to give this lecture to Dr. Agnivesh, so you all don't have to worry. I'll just make a PDF and send it out, so you all will have it for keeps. So don't worry about the data on this lecture. Also remember that India has 1/3 of the population of the world of TB, and that's slowly growing into half. So actually 1/3 of the world's population has TB, and half of that 1/3 is Indians. And in India, there is one death every minute almost for tuberculosis. You got to know that the tuberculosis mycobacterium was named the millennium bug. So they may ask you that, what is the millennium bug? It's MTB. And in which year did the WHO declare TB as a global emergency? So that's 1993. Roughly, you got to know the timeline that in the early 1900s, tuberculosis was a pandemic. It was so bad that it was taking people down. And once the antibacterials were discovered, that's in the between 1940 and 1960, we started getting control over TB. And from 1960 to 1980 maybe was a time when we felt that we had control over tuberculosis, and we thought that we were doing anterior surgery for tuberculosis. We had good chemotherapy available, and there was no drug-resistant TB. It's only when the HIV epidemic hit the world, which was in the 90s, that the combination of HIV and tuberculosis, along with rising trends of diabetes, caused an explosion of the numbers of tuberculosis cases in the world. And that's where in 1993, it once again became a global emergency. One of the other reasons for TB to become global was the traveling of people. So the Asians were migrating significantly to the West, and since TB is carried by them, TB started getting percolated in the West, and there was a second rise of tuberculosis in the 90s. So you got to roughly have this idea in your head. Moving forward, how does TB spine affect your life? So this is what the life of people. So as a postgraduate in orthopedics, you will have 1 or 2 long cases, which will be either TB spine, POTS paraplegia, TB spine with a gibbus. So it could be deformity, it could be infection, or it could be paraplegia. And each one comes with a separate set of questions, of which the TB paraplegia we are probably not going to discuss today because it's a completely different topic. They discuss about bed sores, rehabilitation, etc. You will have maybe a short case. Either it will be a cervical TB with a torticollis, or it could be a gibbus in the spine, less likely. Hip FFD, very common, and the discussion will go on to tuberculosis of the hip, or even a knee FFD. And of course, in the theory, there will be a long question. So tuberculosis, you will have something or the other, equal to, say, I would say 20% of your orthopedic exams will be related to TB. So which is why you got to be attentive and try and get every data that's available to you on TB. Now, as we go, you're welcome to stop me, unmute yourself, just shout out loud, ask whatever you want to ask, and otherwise in the end you can ask, and otherwise you can take the lecture and ask questions later. Now, this is important that TB no longer is considered hematogenous infection, right? So originally TB, it was the way we were brought up thinking was that when I go out in an endemic zone and somebody coughs, he gives out a whole bunch of bacteria, and those bacteria floating around. I breathe in the bug, the bacteria. It goes into my Ghon's focus, which is the first line of defense, the set of lymph nodes in my lung, and then depending on my immunity, it either gets the body wins, or the TB spreads into the lung. So you get pulmonary TB. From there, it disperses into 1 or 2 or multi organs. That was the mode of infection. Now, today we know that in adults, that is not the mode of infection. The commonest mode of infection is reactivation in an endemic zone. So the meaning of that is that all of us here have been infected sometime or the other in our life so far, because 1 in every 3 people in India are carriers of tuberculosis. So we get infected, but our body's immunity suppresses that bug. So it reaches a Ghon's focus, and then it's dabowed, and then it's kept in the sidelines. And so that's why our Mantoux tests always come positive. Because we have exposure to TB, our immune system is ready and it has already won over that bug. And it's when our immunity goes down, that's when the bug reactivates. And that reactivation is the new infection that we get. It's really not a primary infection that we get from a new source. So you got to remember this. This has bearing with the fact that extrapulmonary adult TB is less likely to be multi-drug resistant TB. One of the reasons for this is that most of us had exposure in the 90s or 2000s, depending on how old you are, when the MDR bug was not in business. So when I had my exposure, maybe in the 80s or maybe in even the 70s, there was no MDR bug. So the stuff that I'm harnessing inside me is non-MDR. While children are always inoculated fresh. So the incidence of MDR TB in children is almost 20%. The reason for that is that for them, the mode of infection is the direct inoculation of a fresh new organism. And today there's a lot of MDR bug, in the community. So that's the reason why adult extrapulmonary, less likely MDR, children, very high likely MDR. I hope you understand this. Unless there's a question, I'll go forward. Any question?
No, sir.
So going forward, these are the types or the pathologies of TB. Again, you will be asked this. So there is abscesses, tuberculous abscesses, which can be prevertebral, postvertebral, paravertebral. It can be epidural, it can be intraosseous. So that's descriptive, and you can easily kind of work that out in your head. One of the trick questions that is asked is that can a psoas abscess drain out in the hip? So if you have a leaking sinus in the hip, then of course the answer is yes. The follow-up question is that if you have a psoas abscess, how high could the lesion be? Can anyone answer? So if I detect a psoas abscess in a person, how high could the spinal lesion be?
So it can be as high as paravertebral space goes. So it can reach up to cervical spine.
So how does cervical spine connect to the psoas muscle? So psoas abscess means the psoas, wherever the psoas is inserted, if there's an infection, the abscess tracks along the psoas, psoas muscle.
So the
right?
paravertebral space is continuous, if I'm not wrong.
Yeah, but that's
Okay,
not the right answer,
okay,
because I mean, if you see how the paravertebral muscles are inserted, on the top they're inserted like this. So cervical and cervicothoracic abscesses, they stop at that level at T4, and then there's a mid-thoracic abscess, and the psoas. Essentially, this question addresses what is the origin of the psoas,
okay.
and
So lumbar spine, if I'm
yeah, so the standard answer that people give is that if there's a psoas abscess, you can have TB up to L1 because the psoas actually originates from L1, but that's not true because it's a trick question. Actually, the psoas tendons go through the diaphragm and they go to T10. So the correct answer is that even a T10, T11, T12 tuberculosis can lead to a psoas abscess because it trickles along the tendinous insertion, which goes through the crura and then goes into the psoas. So that's the answer that they will be looking for, right? And which is worse, prevertebral or epidural abscess? Obviously, epidural abscess is worse because even a small amount will cause cord compression because it's a big abscess related to the small space, right? Now you got to know what's the classic lesion. The classic lesion is spondylodiscitis. It's the classic sandwich lesion. As you can see here, you have you have two end plates affected with the disc space affected in the middle. So you have again here end plate, and disc space in the middle. So that's the classic lesion. Again, there are some lead questions that come up here, and we'll quickly we'll talk about those as we go. But you got to remember the classic question is spondylodiscitis. Now this is the question that they will ask you in the exam, that how does the disc get affected in tuberculosis? Now, disc, is the body's largest avascular organ, if you may, or avascular part. So, if it's avascular, how does it get affected with infection? Anyone in the house would like to take that up? We just call this a discitis, a spondylodiscitis.
so because of the blood supply, the nature of blood supply.
What about
So
it?
so blood supply goes directly into the adjacent end plates,
Okay,
and the disc exchanges fluids through the end plate.
correct. You're there. So,
So tuberculous bacilli might migrate in and out.
yeah, so you up to there you were right. So in tuberculosis, the blood supply on the end plates gets choked up or gets thrombosed. Okay, so the micronutrients that go, they actually go through a physical transmission. There's no the blood vessels don't cross the end plate. There's a physical osmosis of the electrolytes across that give nutrition to the blood to the disc, because the disc has no blood supply, and this gets cut off, and hence there's an avascular necrosis of the disc. So the infection actually never affects the disc. It's avascular necrosis. It's very late in the day when the end plate breaks down that there can be pus in the disc space. But the idea behind asking this question is that when you culture the disc, it will always be negative. So it's always recommended not to send the disc for culture, but send granulation tissue or bone tissue for culture, because the disc will have avascular necrosis secondary to tuberculosis of the end plates. That's the answer, and that kind of gives lights up your perspective to the pathology also. So I hope that's clear. Osteitis, yes.
So after this, is the damage reversible or irreversible in the disc?
So once the disc is damaged, it's irreversible. The disc has no blood supply, so it has no regeneration potential. So very often you get a lesion like this that you can see in the central image. This will completely regress, but you can see that little end plate that's broken down. This will lead to a long-term degeneration of that disc. So at the end of the day, for this guy, his bone will completely regenerate, but the disc will permanently and irreversibly degenerate. So disc degeneration is irreversible at the end of tuberculosis. That's the price you
So
pay.
it will always end up in secondary fusion.
Fusion or degeneration. It depends on the amount of physical destruction. So if the disc is just degenerated, so it loses its water content. You know the phases of degeneration of the disc.
Yes,
The
sir.
first phase is where you just lose water content. So the proteoglycans in the disc have gone. The disc will be rendered less springy or with a poorer shape memory, degenerated or dehydrated, but it
The
will
ratio
not
will
get
reverse.
destroyed. Yeah. So if it gets destroyed, then there's a disc space collapse. Then that will lead to a fusion.
Okay. Thank you, sir.
Okay, so depending on where in the disease you catch the tuberculosis, you can end up with or without a fusion. And you will see some cases as we go. So the the odd lesion is the osteitis, which is a central body lesion. So a typical spondylodiscitis would have been 2 end plates with the disc in the middle affected. But an odd lesion is where the entire bone is affected uniformly with the disc spaces spared. One of the key features is that when you look closely, you will find that there's a dent in the end plate above or below. And that's a key feature of tuberculosis or infection, because otherwise a central body lesion is malignancy unless proved, or tumor unless proved otherwise. So if you find this end plate lesion, you're set. The third way that this can present, or the pathology, is a concentric vertebral body collapse. So if this central body lesion remains there, keeps destroying the bone, but doesn't really percolate across, so it doesn't affect the next vertebra, eventually this vertebra will collapse. And again, this is a rare modus of presentation of tuberculosis. The commoner DDs of vertebra plana, again, this is a question, it can be a theory question also, is multiple myeloma, metastasis, eosinophilic granuloma, ABC and GCT. And you need to know at least a little bit about all these and how to differentiate these from infection. So the common reason for a vertebra, in fact, a vertebra plana as per se refers to EG, eosinophilic granuloma. However, it's a very rare condition, and today the commoner conditions which cause a flattening of the bone are also considered as vertebra plana. But the term vertebra plana was described for EG. Okay. Then you have the paradiscal lesion, where you have the adjacent end plates affected, but the disc is completely spared. So these are different terminologies. So just to go back, there's abscesses, there's spondylodiscitis, there's osteitis or a central body lesion, there's paradiscal lesions, and then there are atypical tuberculosis. So that's another thing that they will ask you, that what is the atypical presentation of spinal tuberculosis? So these are all the atypical presentation. One is ivory vertebra. Ivory vertebra is where the the immunity is good, the disease is coming very slowly, and the body is immediately cleaning it up. So there's a lot of sclerotic or reactionary sclerosis in the bone. So the bone starts getting denser and harder rather than getting eaten up, because the immunity and the bug are almost fighting the war at the same plane. Normally either the bug wins or the immunity wins. So in that situation, you get what is called an ivory vertebra. And this is a very rare form of spinal TB. You don't often see it. If you have an ivory vertebra, there's a differential diagnosis. Again, can someone tell me, Rahul, now I think you don't answer, even though you have the answer, which form of spinal metastasis gives a sclerotic metastasis? Which cancer gives sclerotic spinal metastasis, famously?
Sir, I think prostate.
Manoj?
Sir.
Yes?
Sir, I think prostate cancer.
Yeah, very good. So that's all the answer that you need. Prostate will give a sclerotic metastasis. Thank you. The next atypical is neural arch tuberculosis. Neural arch, this term refers to posterior elements. So everything from pedicle to laminae to facets to the spinous process. So the incidence of that is very low. Having posterior element tuberculosis, the incidence is low, and hence it's categorized in the atypical elements. And those are some examples of neural arch tuberculosis. Here, there was a classification. It's a very lame and loser kind of classification if you really read it. But again, in our time, this was again a favorite question when you were doing well. What is, because it was given by an Indian. So it's Kush Kumar's classification, a 4-point classification of posterior segment tuberculosis of the spine. And because it's TB, you really need to know it. So once you have this presentation in your on your desktop, you can go through that slide. It's a busy slide. And when you read it, you will realize it's a really lame kind of a classification. It just doesn't make any sense in terms of treatment. But you got to know it, and you at least got to know roughly about it. At time, someone had asked a short note on 4-point classification of posterior element of TB. What about multiple vertebral disease? So skipped lesions. Does anyone know what is the percentage of spinal TB that is skipped lesions, that shows multiple involvements? What percentage of spinal TB shows skipped lesions? Anybody? Again, you got to know this because this figure was initially 3 to 7%, and it was an Indian paper that changed it to 20%. A paper from a famous Indian surgeon came up, which gave the world a new number. And today, the percentage of spinal TB with skipped lesions with multifocal TB have gone up as high as 20%. Dr. Rajshekharan's paper, which studied MRI scans. So when the MRI is big, so earlier we would have TB of one area, we would do X-rays over there or an MRI over there at best. but we would never really screen the spine. Today, screening of the spine is a dictum. So once you start screening the spine, you realize 1 in every 5 spinal TBs have skip lesions above and below. And so basically the number has changed from 7 to 20%. And skip lesion is when you have one vertebra affected and the next affection is at least one vertebra away. So 2 disc spaces and 1 vertebra away, it's called a skip lesion. If it's either the adjacent vertebra or the disc space adjacent to it, it is not a skip lesion. So that's that. Once again, Khufia question, what did Dastur describe? Again, an Indian surgeon, 1972. So it's an intraspinal tuberculous granuloma, which actually was described much earlier by Seddon, and he called it the spinal tumor syndrome, and Dastur called it intraspinal TB granulomas. There's really, if you go into it, there's not much difference between the two. But once again, in the exams, especially if you have an examiner from the north, he's going to definitely ask you these irritating questions. So you be aware of it. What about percentages? Which area of the spine is most commonly affected by tuberculosis and why? Can anyone answer that?
Dorsal spine,
Why?
because it is closest to lungs.
Right. So that's the standard answer, but the true answer is thoracolumbar spine. Because it's closer to lung and it's still a mobile part of the spine. So being mobile, the immunity is lower there, the chances of trauma are higher there. So TL spine ahead of thoracic spine. So TL, thoracic, lumbar, and cervical. That's how it goes. All right.
Okay.
Any questions? Yeah. So the reason, of course, is that the theory of TB being dissipated from the lung is gone away now. The lung no longer is the source of TB in adults, which is why, the area of the spine that is statistically more often involved seems to be not the thoracic spine. Okay, here's another exam question. The difference between tuberculous giant cells and other types of giant cells, foreign body giant cells or any other cells. So tuberculosis is differentiated by the presence of Langhans type of giant cells. So can anyone tell me what are these, like how do they differentiate? Because there are many other conditions where giant cells are seen. Even that will be asked to you. Which are the conditions where giant cells are seen in pathology? And how do you differentiate a tuberculous or a Langhans type of giant cell? Anyone? Yes? You got to know this, yeah?
Langhans child cells are multinucleated.
Multinucleated. What is special about that multinucleation? You're on the right track.
U-shaped nuclear arrangement.
Absolutely. Horseshoe is the word.
Horseshoe.
So you got it right, Nihal. There's a central nucleus, and then there's a horseshoe-shaped arrangement of nuclei. There are 8 to 10 nuclei that are kept around like a horseshoe, and that is very classic of a Langhans giant cell. Right? So that's the word that you're looking for. Well done. And you will be asked this. Also look up the places where giant cells are seen in pathology of the bone. There'll be a set of differentials. You got to know that. Okay, coming to clinical features, with the advances in diagnosis today, even asymptomatic people have tuberculosis of the spine. Like this guy, this is a clinical experience from workplace. The MRI on the right had no complaints. He has such a big lesion with an epidural compression of the cervical spine at C3, and he still had no complaints. And this was an incidental finding on the MRI scan. However, typically you get pain as the first symptom, and the feature of this pain is night pains. So normally any mechanical pain happens on loading and goes away on offloading. So discs, stenosis, fractures, lysis, etc. But disease pain normally is present even at night because the muscle spasm goes down and the spine is left to its own devices. The muscle spasm acts like a protective splint. In the night, it goes away. And of course, your attention also is drawn there. So you get night pain. So night pain is a sign of disease. Whether it's infection or whether it can be tumor is left to conjecture. So one of the features of tuberculosis is night pains. You may or may not have constitutional symptoms. In fact, constitutional symptoms is not a hallmark of spinal TB because it's extrapulmonary TB. Pulmonary TB becomes more of a systemic disease where you get constitutional fever. So a big number of your spine TB patients will not have fever, weight loss, anorexia, loss of whatever appetite, etc., right? Another question is how many how many patients of TB spine will have a lung lesion on chest X-ray? So when you're asked what investigations will you do, you've got to mention X-ray chest. So the minute you say, sir, I will also do an X-ray chest, the question will be, why will you do an X-ray chest? And how many spine TBs you expect to have a lung lesion? Anyone has the answer? Again, 20 to 25%. So 1 in 4 to 1 in 5 people with spinal TB will have a lung lesion. And why do you do X-ray chest? Because if there is a lung lesion, that becomes an easier source for biopsy, because lungs have an open system. It's not a closed system. The bronchi actually open, so you can do a bronchoscopy and take the biopsy under vision. So which is why an X-ray chest becomes mandatory to your plan of investigations, right? Moving forward, any questions? What about signs? In signs, there will be local tenderness, which is again a hallmark of infection. Most other conditions which are degenerative don't have local tenderness, including osteoporotic fractures. Even if you thump a guy with osteoporotic fractures, he won't complain of pain. But if there is local point tenderness, you got to think of infection as your differential diagnosis. You will, in your exam cases, have boggy paraspinal swellings, and you will always be asked the difference between a knuckle, a gibbus, and a kyphus. It's to do with the number of vertebrae involved. A knuckle is 2 vertebrae, gibbus is 4 to 5 vertebrae, and kyphus is more than that. It's a very silly question, but it's going to be asked. You will have to check neurology, and we'll come to that. The differential diagnosis on clinical features. So typical young adult who has or does not have constitutional features, complains of generalized pains in the body and has a significant amount of back pain. The differential diagnosis is spondyloarthropathy, osteomalacia, and rarely mechanical back pain, right? Coming to diagnosis. So can tuberculosis be diagnosed on MRI scan? And this is a contentious question, which you will have to gauge your examiner's psyche. But most Bombay examiners, who we consider as the modern orthopedic surgeons, will agree that MRI is not the way to diagnose spinal tuberculosis. The world agrees it, but some older or more senior people are so experienced that they can just look at an MRI and say this is TB. The fact is that is hogwash, because you cannot diagnose TB. The TB is a histopathological diagnosis. Infection can be an MRI-based diagnosis, but what infection and what kind of tuberculosis, drug resistant, drug sensitive, those questions are all answered on an MRI scan. So MRI cannot be the method for judging TB. And here are some examples. This is not for the exam, but this is for you to take home as a message. All these patients were on AKT. They came to our clinic diagnosed as tuberculosis on MRI scan, but you see the plethora of differential diagnoses that they actually had. None of them had TB. So all of them look like TB. They have disc space destruction in some places. They have a central body lesion. They have soft tissue. They have pus around. They've got a prevertebral abscess, but they are not infection, right? On the other hand, these are all atypical presentations of TB. These all look suspiciously not like TB, but they actually are TB. So TB can be a mimic in both ways. It can hide or it can overpresent itself. So don't make a radiological diagnosis of spinal TB. That's Dr. Bhojraj there. He's one of the pioneers. He's my boss, and he's one of the pioneers in spinal tuberculosis in India today. And so don't make a diagnosis on the basis of radiology. So if you, in your exam, if you move towards, you finish the diagnosis and you say, I think it's an infection of T12, in the mid-thoracic spine, and given that it's a chronic infection, it could be tuberculosis. And if then MRI is put forward to you, please do not say, yeah, I can confirm that this is tuberculosis. You can at best say, I can confirm, sir, this looks like infection because of soft tissue, because of paradiscal involvement. The likelihood of this being tuberculosis is high because of the clinical radiological match, but I'd definitely like to prove this by doing a needle biopsy. So if your examiner then says, needle biopsy, why do you want a needle biopsy? So you got to judge that person's sense, because the statement that's up there on the screen is also true, that in an endemic area where biopsy is not easy or not accessible, you can still give empirical treatment to the patient. So this again comes in the smaller village basis, but any city clinic will never start AKT without a biopsy, right? So when you're asked, why would you do a biopsy by the examiner? So you reach a point where there's a contentious question being answered. You got to say that, sir, you can treat spinal tuberculosis if you're very sure of your clinical radiological judgment. But I would like to add two things. One is that I will inform the patient that we are giving you an empirical trial of AKT. And number two, I will not be able to decide the kind of bug that I'm treating. So in India, 8 out of 10 spinal infections, which are de novo, not post-op, is tuberculosis by statistic. So statistically, if you identify pus on an MRI scan and call it TB, statistically the chance of you being right is 80%, which is a very high chance. But now in urban cities, especially in tertiary referral centers, there's a 10 to 15% incidence of multi-drug resistant TB. And it doesn't matter if you've diagnosed TB, if you've given the wrong drugs, you've got it all wrong. And hence the need to do biopsy. So when you're asked to defend your requirement to do biopsy, you say that, sir, tuberculosis is a histopathological diagnosis, not a clinical radiological diagnosis. And I need to know what kind of bug we are treating, because that's the correct, then I can give him the correct chemotherapy. And that will not kind of be contentious. So if your examiner then starts to get aggressive, you say, sir, I'm happy if someone is confident of his clinical and radiological judgment, please go ahead. In an endemic setting, I am okay to do that. They will ask you how a biopsy is done. So all these points here are important. Don't go crazy writing all this down, because the lecture will be on your laptop very soon. So you will have all this. You don't have to double your work. You have to send everything that is taken out for smear, histopath, and culture, drug sensitivity testing. They will ask you what is the type of staining that is done. You got to know what's Zeal-Nielsen staining. You got to also send all for even gram staining, because you're not sure of TB when you send it, right? So you're going to send it for even fungal culture, the regular gram positive, gram negative, tuberculosis, and fungal culture. A smear is important because that can give you an instant diagnosis. Histopathology, of course, is important. They will ask you what tissue should be sent. So ideally, if you have only one part to be sent, it should be granulation tissue. If you have an option of 2 parts to be sent, send a part of bone also. And finally, even pus can give rise to a positive culture, because it will have, especially with the gene expert test, pus will have dead bacilli which will be picked up. So it's important to send all 3. LJ medium is the classic medium that was discovered for TB. However, the culture time is very, very high, and hence today MGIT is the gold standard. And here the same result that LJ medium gives you in 3 months is available inside of a month, and it's faster and far more accurate. You got to know the 2 new forms of testing, and these are rapid sensitivity testing. One is a rapid PCR test, which is the gene expert. Note the spelling of expert. It is a proper noun. It's not a common noun. It's not ke ye isme expert hai. It's a company that is called expert, right? So in India, I think there's another name for this. If any one of you know, I don't know. It's used in the north again. We still use the expert kit, but in the north or in the government places, they use some other kit. I forget the name. Agnivesh, you know, something, whatever. There's another name for this, but expert is a PCR test, a rapid PCR amplification test. And here any sample can be given, even a smear negative. So the advantage of expert is that you get a result in 2 hours. The advantage of expert that it's almost 75-80% of the times positive. The advantage of expert is that if it's positive, the chance of it being false positive is very, very, very low. The advantage of expert is you can do it in a smear negative patient, which is common in extra-articular or extrapulmonary TB. Pulmonary TB is commonly smear positive, but extrapulmonary TB is commonly smear negative. So you got to send expert for all spines. LPA, which is line probe assay, which is the less known test, is of extreme value, because the LPA gives, though it takes a day or up to 2 days, it can detect resistance to many more drugs and not just rifampicin, right? So the advantage of expert is that gives you rifampicin resistance. Rifampicin resistance is linked to INH resistance, again, 60 out of 100 times. So if you're RMP resistant, you're likely to be also INH resistant 60% of the times. So it gives you practically, resistant to 2 drugs. But LPA, which is done in smear positive samples only, and it's available over 1 to 2 days, can give you resistance, information about resistance to RMP, rifampicin, INH, quinolones, and aminoglycosides, which gives you almost a look into the MDR status of the patient. So that's an important test. What about ESR and C-reactive protein? Again, you got to hold your own, and in the exam say, sir, these are non-specific markers of inflammation, and I will not do these tests, or I will do these tests, but I will not use them for uh, I will not use these tests for diagnosis, because even cough, cold, fever can give rise to high ESR or high CRP. So what is your, why would you do this? Sir, it's an addition to my plethora of diagnosis, and more importantly, it tells me how to prognosticate the disease. So when I follow up the patient, if the ESR and CRP shows a lowering trend, it is one of the other ways that I'll know that the TB is improving. So that's why I would do this test, but I would not diagnose on the basis of high ESR or high CRP. Another question that's linked to this is that they will ask you, if your ESR is above 100, what's your likely diagnosis? The answer is multiple myeloma. So in tuberculosis, the ESR goes between 40 and 80. In multiple myeloma, it goes beyond 100. And Dr. Agnivesh has told me that the Indian version of the gene expert is the TB NAT test, or I think is the CNAT test, TB NAT, which is nucleic acid amplification test. And that's the test, the name of the test that the government of India recommends, which is the same as the PCR or expert test. This is another contentious problem, that TB IgG and IgM, again, they are only as good as your Mantoux tests. So we will expect all Indians to be positive, and you cannot, it's a government rule now that if your TB IgG is positive, you're still not in a position to call this tuberculosis, and you got to just let this go. All right. Coming to X-ray, the X-ray findings are multiple. You all know the first finding, of course, is rarefaction of the bone, like in any infection. The next finding is end plate destruction. Once you start seeing that, then the collapse, kyphosis, etc. will happen. But the question that they'll ask you, what is the first finding? It is rarefaction of bones and sometimes soft tissue shadows. The next finding is end plate damage. Of course, the fallacy of X-ray is that it takes a lot of destruction. It takes 40% decalcification before it will show up on X-ray. So there's a 3-month lag between the time the spine was affected by the infection and it really started showing up on an X-ray. So you miss out on very valuable time, and hence it's not, not the test for diagnosis today. And anyone who you suspect with tuberculosis, you got to do an MRI for. This is a favorite question of the examiner. This is what I was talking about with Rahul before some time, that there are different shadows seen in different areas of TB affection, and that's out there. V-shaped shadow, bird's nest shadow between T4 and T10, and below T10 psoas shadow. And what is the normal width of the prevertebral distance? So the distance here, and what is normal and what is considered abnormal will also be asked. So again, this slide will be with you, so you can study these figures and give them back. So the MRI scan is the gold standard for diagnosis of tuberculosis, because it's the lag is literally weeks. The MRI can pick up 1.5 weeks of infection. So it's a very, very early diagnosis. And of course, the next advantage is that it gives you the whole spine sequence. It delineates the exact issue, extent of the soft tissue, exact extent of osteitis. It tells you what's happening to the neural structures. So short of biopsy is the most accurate method of diagnosis. And these are all the classic features. The earliest sign that you see is a hyper intensity in the T2 image, which is bone edema. The next thing you will see is an end plate breach, and then you will see soft tissues of varying amounts. This is a huge soft tissue, but you can see much less. There's a school of thought that believes that tuberculosis emanates in the spine from the costovertebral junction in the thoracolumbar spine. So you will always see the lesion starting up here. And this is where you will first notice your first soft tissue of spinal TB in the thoracolumbar in the costovertebral junction. What is the fallacy of the MRI scan? Can someone tell me? What is the problem with MRI scan in spinal TB? Or which are the places in the spine where the MRI is not that useful? Anybody? The quieter ones? Gayatri, Vaishnav, Jitin, Jennifer, Ajinkya, Tarun. So which part of the spine is not well covered? Well, that you got the answer there. It's the occipitocervical junction is poorly delineated by the MRI scan. So OCTB often gets missed. And the only way to really diagnose it is clinical. You get limitation of rotation. So the person will come in intense neck pain. He has inability to hold his head, but this movement is still fairly restricted. His MRI is reported normal. But you ask him to do this and he will be blocked. And you ask for a CT scan, and a CT scan will nail the lesion in C1, C2. Exact same for sacroiliac joint. The MRI can't differentiate between It can, but it very often misses differentiation between inflammatory and infective, and a CT scan will pick that up. So these are the two places where CT scores better than an MRI scan in spinal TB. Of course, the other fallacy of the MRI is that is oversensitive. The MRI looks so, so many bones will look edematous that you will start, looking at this patient with a lot of suspicion. Prudence suggests that you got to judge the man, not the scan. So you judge the amount of involvement by the person's clinical, situation rather than the MRI scan. Look at X-ray. So downplay the MRI is oversensitive. So those are the fallacies of MRI in spinal TB. Coming to treatment principles, and we're moving on to the second part, which is how to treat. And there are protocols given, and I think all of us are should know Dr. Tully's regimen, which is the middle path regimen. What is this middle path regimen? Middle path regimen is a non-aggressive regimen for treating TB. So the history of this is that after we started getting good at surgery, worldwide, we started doing aggressive surgery on spinal TB, and we started excising tuberculous lesions. As the chemotherapy started improving, we realized that we don't have to excise the lesion. The lesion will regenerate if the correct chemotherapy is given. It's not a tumor that's destroying the bone. So you don't have to really remove it. And the Hong Kong group, which was spearheading this anterior, Hodgson's approach, where you go from the front, excise the TB and replace with big bone grafts, was then gave way to Dr. Tully's treatment, which was more of a conservative treatment. Conservative means it would, you do surgery only in extremely advanced situations. And Dr. Moon from Korea further added to this, and this famous line is given by him that in the absence of grotesque deformity and deadly complications, tuberculosis of spine is a medical condition, right? So what is this middle path treatment? Middle path treatment is really to conserve or to not offer surgery unless there's gross neurology or a gross deficit. And we'll come to that. There are standard guidelines of AKT, but today again, urban doctors will all agree that there is no role of giving, for drug treatment or primary line AKT for more than 12 months. It typically is intensive phase for 2 months and then continuation phase for 7 to 10 months. There is no benefit of giving injection streptomycin. In our time, orthopedic surgeons used to find streptomycin as a hot favorite, and they would say the penetration is better with streptomycin for bony lesions, but that's been proven to be untrue. You have to back up all your patients with vitamin D and calcium, especially vitamin D, because vitamin D linked immunity will actually help the body to fight the disease. And you got to give appropriate activity modifications. Remember to ensure correct dosage of treatment at the start. So once again, if you're doing very well, they may ask you that how will you manage this, the medical treatment. It's important that you tell them that the rifampicin is to be taken first thing in the morning. It should be taken on an empty stomach. After taking rifampicin, you should not eat or drink or lie down for 45 minutes to an hour. You also have to tell them that your primary AKT will cause discoloration of your urine. So don't panic. It's a normal phenomenon. And tell them the importance of continuing treatment, the importance of short course multi-drug therapy followed by a long course less drug therapy, right? Intensive phase and continuation phase. There is no role of adding one extra drug to your 4-drug AKT. And these are all the principles of giving primary AKT. Where would you give steroids? So steroids have a huge neuroprotective effect. So if you have an early neurological involvement and you still decide to treat this patient non-surgically, use of intravenous steroids, though it's not been documented, is definitely on the cards. My advice to you is typically in the exams, if you have someone who has neurology, you err towards offering surgery than conservative treatment, because it's a bit controversial. But in practice, we offer non-surgical treatment up to grade 4 neurology also. It's only grade 3 and below when we say that you got to do surgery. And again, these are very ill-defined lines. These are blurred lines. There's no clarity as to who will offer what. So in the exams, it's safer if neurology is clinically present, you offer surgery. It's only when you don't offer surgery in neurology, you use steroids. Typically, they will ask you how often will you call the patient back. So because these patients have a structural problem, you can't keep calling them back. So at least 3 monthly, you got to call them back. Ideally, get an X-ray and get blood works done every 3 months. And before stopping AKT, you got to, so it's a safe time of 12 months that you can tell your examiner, I'll continue AKT for 12 months. And before stopping AKT, I'll do an MRI scan if available. If the examiner makes his eyes big and says, "Mera iske kyun chahiye?" So you can say, "No, sir. If it's not, if it's a problem, I will not insist on it. But it will confirm that my, my disease is healed, and it will tell me what the spine looks like when I've stopped AKT, because recurrence rates of tuberculosis of the spine after completion of good AKT are in the range of 5%. So if the patient comes back after some years with a lesion, I have a documented comparison of what his spine looked like at the end of treatment. And I don't start pointing fingers at lesions that were pre-existent when he comes back. So that's the reason I'd like to do an MRI. But if the examiner is aggressive, again, it's not critical to do an MRI while stopping AKT, but you got to argue your way correctly. You got to know a bit about DOTS, but you also got to know that DOTS is now given up, mainly because they found that it was not logistically okay, especially for tuberculosis of the spine, where the healthcare worker would have to go home and give the drug because the patient was not available to walk to the clinic. And also the results of DOTS were not, there was too many relapses after DOTS. So DOTS has been given away. You got to know the WHO categories. When this lecture was made, there were 3 categories. Now there's a 4th category. You got to know the RNTCP guidelines. I've not put that up here. Maybe a month before your exam, you go to the website and find out what's the latest current, because it changes every 6 or 8 months. The guidelines from the WHO and from the RNTC, but you got to generally know, because if you have an examiner from Delhi or UP or someplace, they will definitely grill you on this and take this to the wire. So you got to know this. How do you monitor recovery? Priority wise, you monitor recovery on clinical grounds first. So if the patient says my pain is better, I'm eating well, I'm feeling generally happier, generally better, my mobility is improved. If clinically I'm able to demonstrate that his spasm has gone off, his spinal mobility is better, his local tenderness is getting better, that's my number 1. Number 2 is radiology, whether it's X-ray or MRI scan. In the exam, it's safer to say X-ray. And number 3 is labs, which are corroborative evidence, a reducing trend in ESR and CRP. But none of these standalone can tell you that the patient is getting better. You got to put all this together. But the number 1 important criteria for improvement is clinical improvement, right? Any questions so far? So there are some people, especially neurosurgeons, who strongly believe that AKT doesn't penetrate the neural barrier, and you got to give, once the brain tissue is involved, you got to give AKT for longer than up to 18 to 24 months. But this, this theory has been trashed adequately in literature. So you try to stick to 12 months as your stand, and you should be able to argue it out. There's enough data now available. We've been a part of a prospective randomized trial proving it also. So you got to kind of be well read on that when you talk. This is that trial. No, this is MDR TB. So anyway, so as far as duration of TB is concerned, judge your examiner, but I would still advise you to stick to 12 months for TB spine and not go beyond that for primary TB. Now, MDR TB, XDR TB, and TDR TB were not known to affect the spine till we were the first ones to. Agnivesh, were you in the part of this? I think you were, but your name is not there. But we were the first to present the series of MDR TB in the world for spine. This was in 2009, 25 cases MDR TB of the spine culture proven. The question asked will be, what is the meaning of MDR? Does anyone know? What is MDR TB? There's a specific definition.
Resistant to both isoniazid and rifampicin.
Yeah, perfect. So INH and rifampicin resistance is called MDR resistance. So if you're resistant to PZA, it does not mean MDR TB. This is important because they are the most important lytic drugs. They're the ones that actually, bactericidal drugs in your regimen. If you don't have those available, then you're treating, with a very, very poor armamentarium. So well answered. There is primary drug resistance, as you can see, and that's the children that we said. Kids on whom there's a direct inoculation of a resistant drug, a resistant bug, will have primary drug resistance. More commonly in our country, there's secondary or acquired drug resistance because of inadequate dosage of your primary drugs or poor compliance from the part of the patient, right? So faulty prescription by the doctors, especially weight related. So you got to know the, which drug is what milligrams per kilogram body weight. There's a standard thinking, 5, 10, 15, 20, 25. And you should know that, and that's one of the causes, important causes of drug resistance, which is acquired. So this is MDR. The mono resistance is drug to any one TB drug. Polyresistance is resistance to 2 or more. This is a lame definition. But do you know what is XDR TB? extremely drug-resistant TB?
Along with rifampicin and isoniazid, there is resistance to fluoroquinolones.
And
Injectables.
One of the
That's
injectables.
right. So you got it. Injectables as well as chloroquinolones, because the first two drugs in resistant TB given are chloroquinolones and one injectable, which is one of these: kanamycin, streptomycin, capreomycin, etc. So if you have resistance to both of these, it's called extremely drug-resistant TB. And again, we have reported one case of XDR TB in a spine of a child. So it's not unreported in the spine. Does anyone know what is TDR TB? Totally drug-resistant TB. So TDR TB means the patient has resistance, or the bug is resistant to all the drugs that are sensitizable on the microbiology report. So we have ability to look at sensitivity of about 15 or 16 second line AKT. If all these are resistant, it's called totally drug resistant TB. Okay, but there are many drugs which are not covered in that group, and hence you treat totally drug resistant TB with that. The mortality of drug-resistant tuberculosis is 20%, which is as high as the mortality of breast cancer. So it's a totally different bug, totally different disease. Does anyone know which is the magic new drug for MDR-TB? Which is hit the headlines, caused a lot of embarrassment to the government. They will ask you, it's bedaquiline, yeah? Bedaquiline is the new drug, which is, they're saying it's as good as rifampicin, as sharp as rifampicin. And it's extremely effective, but it's extremely expensive, and it has to be used with caution because you don't want to create resistance to bedaquiline also. And then the WHO has given guidelines on, once again, these have changed recently, but they've mentioned 5 groups. So when you start treatment, this will not be asked to you unless you're getting a gold medal. But if you're asked this, you can be sure that you're in the toppers. There are 5 groups that have been described. So you got to give one drug from each group when you start MDR treatment. Your standard answer should be, sir, I will not treat MDR. I will hand it over to a chest physician for treatment. I will not treat. But if they still ask you what are the groups, if you know this well, you get your gold. What about indication for surgery in spinal TB? So these are quite standard question, standard answer. Here you don't break a sweat. So significant neurology. What is significant neurology? Neurology enough that the patient is unable to walk, which means grade 3 or lower power, in my opinion, is reason for surgery. If the diagnosis is in doubt and I've tried biopsy, surgery. If there is neurological deficit or pain or instability not responding to conservative treatment for longer than 6 weeks. Now, why 6 weeks and why not 8 weeks and why not 4 weeks is, it's never going to be contested. But the good part about orthopedic surgeons is that you say 6 weeks and everyone is happy. Wherever you're in doubt, you add 6 weeks and everyone's going to be happy. So your 6 weeks is your golden time. Children in which you have these high risk signs, which we'll come to, they become an indication for surgery. And of course, late onset paraplegia or late sequelae of TB are often indications for surgery, right? So cord compression alone, so on the MRI, if there's cord compression, but the patient has only brisk jerks and no loss of motor power, you need not do surgery. But these are the ones where you can use steroids in the part of your treatment regimen. And these are all MRIs showing how the abscess is completely resolved, the bone is completely regenerated, just leaving a degenerated disc behind at best, with medicines alone, without any without any surgery. So you got to just see these cases to convince yourself this is not exam related. This is more like practice related in life. When you see cases like this, surgery is sometimes far more difficult to perform in these conditions than given medication. And that's Dr. Tully saying that you will not insist on surgery because of radiological cord compression or early hyperreflexia. And that is really the sum and substance of his middle path regimen, right? And we also published a prospective series of 50 patients who had hyperreflexia or early neurology and cord compression on MRI. And 47 of them did not need surgery. So it's a significant number. So these were all excuses in our times. Like in our times, the DAS textbook said that if there's an abscess, if you don't drain it, it's never going to get better. So an abscess becomes an immediate indication of surgery, whether pyogenic or tuberculous. Today, we know that at least tuberculous abscess is completely resolved. So it's no longer an indication. In our times, it was said that a high disease load, so a lot of affection, if you go and do surgery and remove the disease load, the drugs will act better. But that theory also has been trashed. Drug-resistant TB, if the drugs are correct, you don't need surgery. Spinal instability in TB is normally a transient phenomenon. As the bones start to heal, the instability goes away. Of course, kyphosis and neurological deficit we discussed. What are the surgical options in TB? So there are two things that you definitely need to know. Normally, it will not go beyond that. So one is Rajshekharan's criteria of of posterior column integrity, and these are the spine at risk signs which have become very, very popular in pediatric TB. Pediatric TB is TB in a growing spine. So the difference is that the spine has an ability to correct itself or to actually spin out of proportion and get worse. And hence, if these four criteria are seen in a child, there's a high likelihood that his kyphosis will increase significantly if you don't operate him. And these become absolute indications for surgery in children with TB. As far as adults is concerned, this is the second thing that you need to know, that if the lesion is purely anterior with no kyphosis, you do anterior surgery. If the lesion is global, you should do a posterior surgery addressing all the columns. If it's a global lesion with a poor risk patient, your approach should be only posterior. And if it's a pure posterior lesion, you do only posterior surgery. So this, I'll show you a slide which sums it up. Right, it may come up somewhere. Your approach should always be, here, this is the one. Your decompression is always, the compression is always from the front. So your decompression has to be from the front. The stabilization should always be from the back because the bones are least involved at the back and they provide best anchorage. The reconstruction has to be from the front. However, all this can be done through a single posterior approach. So today, most surgeons prefer the posterior approach, though they will still decompress from the front of the cord. So posterior approach does not mean laminectomy. It means your incision is behind, but you go around and decompress the middle column. So like here, unless this is decompressed, you're not getting anywhere. So, just to exemplify here, your approach will be from the back. So this will be your approach, but you will go around the cord, okay, and take away the middle column. You don't have to remove this whole block because this is going to regenerate as you go, right? So you just remove the middle column, then you fix from the back because the fixation points are least affected from the back. The pedicles are least affected. If you put screws in the front, you're putting one screw per bone. Here you're putting two screws per bone. In the front, you're putting cancellous screws. In the back, you're putting good cortical screws in the pedicles. So there's no comparison between the fixation from the front and from the back. So again, to come back to how you would do this, you would approach this from the back. You would decompress from the middle column, which is from the front, and then you would fix from the back also. Okay, I hope that's clear. Any questions? I seem to have lost my cursor. Any questions? Yeah.
One question is there, why does this vascular get affected in spinal? I'm not getting the answer.
Say again, you're breaking up.
So one question that you asked in the middle of the presentation, why does the avascular disc get affected in the spinal TB?
Yeah, so we answered that right in the beginning. The disc gets affected because of end plate thrombosis. The blood supply to the end plate gets thrombosed because the TB attacks the end plates because that's the maximum vascular part of the bone. When it attacks there, it causes sclerosis and it blocks the blood supply from dissipating across the end plates. So there is a lack of nutrition or lack of vascularity, which is actually not vascularity, just nutrition. And there's avascular necrosis of the disc. So basically the disc gets cut off of its supplies and hence it collapses. It doesn't get infected. That's the right answer. And this is important because you can't culture from the disc. You got to remember that. The disc culture will always be negative because there's no bug in it. The disc is dead, but it's necrosed.
So I have a question.
Yes, please.
During my residency in first year, I came across a patient who was 9 years old female, and she had developed neurodeficit. So it was a clear indication for operative management. So she was operated at 4 levels, and most of the infection was cleared off. But she presented 3 months later with pouring pus. After that, we attempted to treat her infection for following 2 years, after which implant removal was done when she was 11. And she could walk with brace, but until the implant was removed, she kept on pouring pus no matter what we did. So what is the risk of infection that we should keep in mind if we are operating on
Yeah,
an
so
active
there's
TB?
almost no risk of a new infection when you're operating an infection. That is the orthopedic funda. So if you have a pouring pus after surgery for an infection like tuberculosis, the highest chances that your medicine for tuberculosis is not adequate. So if my patient comes back to me 2 weeks after surgery with pus from the wound, or even 2 months after surgery, the first thing that I'm going to sharpen up is my AKT. I'm going to give better AKT. The chance of a new surgical site infection in a case of an infected spine, which is operated for an infection, is very, 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 very low. So in this particular case, my guess is that the AKT was inadequate or incorrect. And if you were to just change that, that would have sorted out the problem.
Okay, sir.
All right. So good questions, good experiences from all of y'all. So this is how you do it. You always go from the back. You may be asked an X-ray like this. So in our ASSI exams, we ask this X-ray. Does anyone know what this implant is? What implant is being used here? It's a Hartzell loop rectangle, spinal loop rectangle with sublaminar wires. So here you put wires under the laminae and tie them against a rectangular stainless steel rectangle, and that gives rise to a dynamic fixation because it's not a rigid fixation. The wires are extra corticular. They go around the lamina. They don't go into the bone. So it allows some kind of a collapse in the front. The downside is that this is stainless steel and hence it's not MRI compatible. As you can see, post-operatively CT scan has been done. Right? And then you got to know how reconstruction. So when I told you about anterior column reconstruction, if there is no gross destruction of the body, you need not reconstruct because AKT will reconstruct the bone by itself. But if there's a gross destruction, you got to be able to put the cage or put a bone graft from the side. Once again, in the exam, you better answer bone graft than cage. Though it has now been proven that in TB, titanium cages are safe. They do not harness infection. But in an exam situation, you say, I'd like to put bone graft. It's a more biological and more correct method of treatment. So once again, in the olden days, this would have been treated by anterior surgery. If you go anterior here, so again, for just to, warm up your surgical spirit, if I go from the front here, I'll have to do some wrong things. One wrong thing is I'll have to excise this entire bone. The next wrong thing is that once I put my strut over here, I will have to use a single screw per bone. I can't put a screw here because this bone is destroyed. So I'll have to span a disc space. So I'll put one screw here, maybe one screw here, and put a rod. So in the end, I've removed too much bone, right? So I've ended up removing bone unnecessarily. And I will have fixed less strong or tacky compared to going from the back. The advantage of going from the front is that it's a direct attack surgery, which means I've directly worked on the I've directly attacked the disease rather than going around the cord, and I have not needed to needed to address the cord before the disease. So first I see the disease and then I go to the cord. So the chances of neurological deficit are less. So if your examiner seems from that anterior school of thought, which some examiners are, you may want to say that you will do an anterior surgery. But you got to tell them that the anterior surgery will have these disadvantages compared to a posterior surgery, which will allow, sorry, I'm going back. I've just lost track of this mouse. In a posterior surgery, in this case, as you can see, multiple screws have been put from the back. So you have a long fixation, 2 screws, pedicle screws per bone, and you've still been able to do a good reconstruction from the, from the side, without removing too much bone. You've just removed the cavity, but you've not removed excessive bone. So you've actually spared one more disc space. So from going from the back, you just optimally remove the disease. You remove only as much as you create the slot to reconstruct, and you don't extirpate the disease. You rather reconstruct in the cavity, and that's the advantage. The other advantage of posterior surgery is you can do very good kyphosis correction because you get a long lever arm at correction. When you're working in a kyphosis going from the front, it's very hard to jack open the kyphosis. So, posterior in a kyphosis is again a no-brainer compared to anterior. And most surgeons today prefer the posterior approach. It's also much easier to do. But remember that no matter what surgery you do, if you don't give correct second line, correct AKT. So in this case, this was in the early part of this millennium, that 2006, We did a very good that time we were doing anterior surgery. We were good anterior surgery. We were happy with the post-op result. She was walking around, but no one traced her culture report. And she came back with pouring pus, like you said. And she came back with an early deficit because the pus was inside also. And then we traced the report. And as you can see, she actually had resistant TB. And that was the reason why she came back with pouring pus. So just the point that you made is seen in this patient. At 3 months, she needed a change in AKT and no resurgery, and she was fine. So she did not need us to go in again. What are the long-term sequelae of heel TB? We know that reactivation in 5% of patients, progressive kyphosis, late onset paraplegia, myelomalacia, and rarely lumbar canal stenosis and lumbar TB. So to sum up, remember biopsy for all, have a high grade of clinical suspicion, don't make radiological diagnoses. In fact, as a postgraduate student, you got to just make a diagnosis of the pathology. So this looks like infection of the spine. This looks like this level. This is the rate of amount of neurological involvement. I'd like to investigate further to find the diagnosis. If you say that, sir, my diagnosis of TB is TB spine, you will get badly grilled by the examiner. Remember that spinal TB is a medical disease unless there's a grotesque kyphosis or unless there's major neurology. There's your non-surgical protocol, like I said, before your exams, read up the WHO criteria and RNTCP guidelines, because they will be very fresh for your exam. And 12 months is the amount of time that you give AKT for. In MDR TB, the mortality is 20%. The drugs have to be given by a chest physician. Lot of side effects of these drugs, and the usual time that these drugs are given is more than 2 years. And when you do surgery, remember, think posterior. So approach from behind, decompress the middle column, reconstruct from the front, and fix from the back. So that's that long and heavy lecture. I don't know how long it took. I tried to be fast. Yes, an hour and 15. So I'm going to share this lecture with your mentors, and you can have it. Agnivesh, I'll mail you a PDF.
No, I have the recording of this complete lecture, sir. So we will not leave you.
Yeah, no, but PDF we de dete na, because recording may be tedious for them. Recording you can give, but PDF you can just give them. They deserve it. Yeah.
So this lecture will always be available on the YouTube channel. So
Okay.
Anybody who whenever wants can go to the link and same link and see the video over there.
Okay, all right.
I will share the PDF lecture.
Yeah. What we didn't cover here was childhood TB, cervical TB, because Agnivesh, I think someone else is covering cervical, occipital TB. Na?
Yes, that is altogether a different ball
Different
game.
topic, yeah.
It's
So
altogether
just to tell them what all is needed. Also, the dosage of AKT you got to know, the common side effects you got to know, and like I said, the government guidelines you got to know. What is DOTS, what is CAT1, what is CAT2, and all that, which I have not covered in this, which you have to just read up.
Yes. And starting with this, sir, if I may ask a few questions, so we all, for the benefit of the residents and all, is that would you prefer to do the TB treatment on your own, or you would prefer it to be done by a chest physician, or even for a normal non-drug resistant TB also?
So I would definitely give it off to a chest physician, because they are meant to be doing it. They have a much better handle. But the reason really is that a lot of side effects come out of your AKT. And hepatitis happens almost in 10% of people with primary AKT. And if you get hepatitis, you then have to transport the case to a chest physician or a pulmonologist, and that person comes in too late. So the reason why you can defend your answer in the exam, in practical point of view, it's a no-brainer. You have to refer to chest physician and not get involved in it. But in the exam, you got to cite side effects as one of the reasons. But once again, if it's a senior old-time examiner, they're very kind of possessive about this, and they say, no, we as orthopedic surgeons have to know the dosages and we have to give. Why should you refer? So you judge the examiner and give your answer, but in practical parlance, it has to be a chest physician.
And one of the questions which was a very favorite during my time, which was much after your time, is what were we being asked is that what is the difference between a vascular cord insult in case of a tuberculosis versus a compression deficit?
Yeah.
So how do you?
Again, we didn't. So I'll lead up to that question by another question that was favorite in our time. That what is the earliest sign of neurology in spinal TB? So the earliest sign is that the person can't negotiate stairs. Okay, that's the answer they're looking for. So why stairs? Because lack of coordination is your first symptom. So why? Because TB is an anterior disease and your anterior columns get affected first. So your corticospinal tracts get affected first. So after this, they say, okay, can you draw a cross section of the spinal cord for me? And that's how this, Viva would go. So well, the vascular insult is a global insult. So when you have a vascular post-operative deficit or even a pre-operative deficit, if it's a sudden, complete sensory motor loss, it's likely to be vascular, which means that a sudden, one area of the cord, the blood supply has got thrombosed, and that area is actually necrosed. So it becomes a global insult. While typical compressive insult is a slow, progressive, initially motor, much late sensory, initially anterior tracts, much late posterior tract kind of an insult, and it's never a total sudden insult. So this basic answer you should, and this will lead you to what is the artery of Adam's quiz, and that the Viva will go on to that. So you got to know that. But thanks for bringing this up, Agnivesh, because I didn't put it in the slides.
No, that's great, sir. That's very great. And one last question regarding the pediatric TB, because we had just touched that about the Rajshekharan sir's those risk signs. So if the risk signs are present, does it mean that we go in and operate immediately, or does it mean that we have to monitor it more closely and take a call that do you want to operate now, is the right time, or you wait for some time and then operate?
So the risk signs are red flags. So if you have a 2-year-old baby with risk signs, so what does a risk sign actually say? The risk sign says that mechanically the spine is going to fail. It has got nothing to do with TB, but the destruction has happened in such a manner that even if you get the AKT right and dry up the TB, the mechanical spine is now in such a way that as the kid grows, it's going to go into kyphosis, right? So that's the thinking. Now the question is, how old is this? So today, mostly we all believe that, and we all accept that if the signs are there, you're going to need surgery. However, most of these kids are very small, so you're not really able to do surgery at the age of 2 and 3 sometimes. So a more correct approach is that it should be a red flag, and you got to flag this kid, and in your mind you got to put him in the surgical list. But actually, go ahead and plan a surgery when it's feasible, right? So when there are red flags or Rajshekharan's spine at risk signs present, the child becomes a red flag for surgery. Doesn't mean you go in now and do surgery, but you watch his kyphosis, and the closer he is to a growth spurt, that's when that kyphosis is going to suddenly go into a accelerated zone. So kids closer to growth spurt have to be watched much more carefully, or sometimes preemptively operated, which means a kid who's around the 5 years age group and around the 10 years age group, if he has spine at risk signs, you sometimes may do preemptive surgery. But someone who's 6 or 7, you can wait for 2-3 years and then do the operation. But the likelihood of a kid with spine at risk signs needing surgery is extremely high, as per the current belief.
All right. And one more last question, which the examiner may ask, is if they refer to gene expert. I think the other name for gene expert is NAAT, NAT, the nucleic acid.
TB NAT.
TB NAT, yeah.
You answered that, so I mentioned it to everyone that you answered it.
So why is only rifampicin resistant?
Sorry, it's CB NAT. CB NAT is the right answer. CB NAT for whatever, I don't know the full form.
Yeah. So and NAT is nucleic acid amplification test, but I don't know what the CB is.
That's some government company. It's like, yes. Expert is a private company from abroad.
Because even the COVID also now, which is done on the same gene expert, is also labeled by the same names.
Yeah, correct.
So what is the significance that only rifampicin is sort of tested, resistance is tested?
So I don't know why only, but that's how the test is. So the test gives rise to tells you only about rifampicin resistance. Any answer you have for this?
No, I think the main answer which came out from our own study was that rifampicin resistance coincides with the maximum MDR. So any patient who has got a rifampicin resistance, there's a 85% chance that he's resistant to other drugs also.
INH also, basically.
Yes, INH.
Yeah. So INH and rifampicin resistance overlaps, almost 6 to 8 times out of 10. And one other question pertinent to this is that 30% of Indians have genetic resistance to INH, and which is why all drug regimens have a PZA in them. That's one of the reasons. Someone on the chat group is saying it's cartridge-based nucleic acid amplification test. That's why CB-NAT. Cartridge-based nucleic acid amplification test. Again, the North examiners are very, prone to asking these. I call them idiotic questions. There's nothing like an idiotic question, but this is something that's kind of, if you have an examiner, once you know from the North, you got to read a lot of theory stuff that, will be asked by them.
Right. So any questions from the residents or the participants? Because this is the best time, you have the best person in hand. You can ask as many questions as you want.
I think it was thorough enough, or everyone was asleep. Yeah.
It was absolutely fantastic. Yes, Rahul, please go ahead.
So my question is related to prevention of TB. Uh, at this time, like we are following preventive measures for COVID. So is it wise enough to continue this to bring down the incidence?
If you do this, you know vicariously the incidence of TB is significantly dropped. But as far as we are concerned, no, we are only dealing, you and me are dealing with extrapulmonary TB. And that is not going to be, it's nothing to do with use of masks. So
Okay, sir. But
really speaking,
my-
it's your immunity.
if I may interrupt, sir, please.
Yeah.
Okay, so my question was because most of the extrapulmonary TB that we come across in spine is usually secondary from pulmonary TB, if I'm not wrong, sir.
No, you're wrong there. That's what I meant.
Okay, sir. Sorry, sir.
No. So I'll just reframe that in the past, it was true that I go into a train, someone coughs and the TB germ goes through my lung and reaches the spine. But today, most of the spine TB is a reactivation of an old TB, which means that when I was 5 years old, this process had happened, which I described, that I went out and I got inoculated with TB, but my immunity dubbed that TB and kept it in a sealed box in my body, which means
This is
that
what you
my
said in the
immunity
beginning,
won
sir.
over the TB. And when my immunity dropped because I got diabetes or got HIV or stress or vitamin D deficiency or multiple, I did some massive diet, the TB came up, So, Amitabh Bachchan had TB, Aishwarya Rai had TB. They are not exposed to public and they are not, living in jhopatpattis. But the reason for that was low immunity because of various diets or various other diseases they had as comorbidities. So it's a reactivation of TB, which is in your immune system, in the systemic disease. And why does it affect the spine? Because see, the spine is the biggest set of bones. So amongst the osteoarticular TB, spine is the commonest place to get TB. But extrapulmonary TB, osteoarticular, I think forms 30% or 40% of extrapulmonary TB. So those percentages are different. So anyway, so the answer to your question is that if you wear a mask, a kid who's never been exposed will of course get protected from spinal TB. But for you and me, the way to protect against spinal TB is to keep your immunity in good shape, keep your vitamin D high.
Get it, sir. Thank you.
Yeah. Good. I'm happy with the interactions, and I'm always available for any other questions and related to anything else. And Dr. Tiku is my bap actually. Whatever I don't know, I ask him. So if he's available to you, then you're blessed.
No, sir. I am really really, it intrigues me. It makes me so much sort of learn new things. Every time I hear your lecture, it's something new I learn. And right from the days when I was getting trained under you.
Yeah. But this is old wines in new bottles.
So Big Boss sir is here. Siddharth sir is here.
Big Boss, wine time now.
Thank you very much, Abhay.
Thank you,
Excellent.
sir. Thank you.
I was there throughout.